And now it's the crucial thing. We're going to talk about the nephritic-nephrotic spectrum. Okay. So nephritic-nephrotic spectrum. First of all, as I told you, all the nephritic, or in other words, all the glomerulonephritis can, and they don't have to, but they can, if they progress, they can end in nephrotic syndrome. That's crucial. All of them. It's not working the other way, because, for example, if you have nephrotic syndrome due to diabetes, which is the most common cause, diabetes and hypertension, that's the most common cause. No, it won't, of course, cause a nephritic syndrome, not so much. Okay? Remember, all the nephritic can cause nephrotic at the end. And what you should imagine under nephrotic syndrome, it's very easily defined for you. Because anytime the proteinuria goes over 3.5 grams per day, it's nephrotic syndrome. And if there's some still inflammation going on in the glomeruli, so it's overlapping, okay, but you can call it nephrotic syndrome. So nephrotic, very simply defined, and everyone understands, is more than per day. Even better, more. So it could be 5, it could be 10, okay? Even better for today, because you don't want to collect, urine in for 24 hours and then to count all the proteins over there or weight them. Even better is a one spot, you call it spot protein creatinine ratio. So basically now the patient gives you urine because he peed in it, and you just take this sample and you put the amount of proteins to the urine into a ratio. Okay, so if it's a spot protein to creatinine ratio, that means in the urine, it's very simple. Remember, if it's more than 2, so if there's 2:1, it's in milligrams. Both you measure them in milligrams, so you have to use US units. And if it's then more than 2, so it could be 4:2, it could be 5:2.5, okay? So if this is a protein in the urine, and this is a creatinine in the urine, if these are in this ratio 2 or more, it's a nephrotic range already. So the patient in 24 hours is going to lose more than 3.5 grams. And this is crucial. And I don't know if you know why this 3.5 is such a magic number, but I'll tell you. It is the number that we like from experience. So empirically, we know that if you pee more than 3.5, if you lose this amount, the liver is not able to catch up. Because if you would be using only 1 gram per day, it's okay. Still, if your liver is okay, you will sort of generate enough of albumin and sort of oncotic pressure. It's going to be decreased, but it won't be, so bad. But at the moment you go over 3.5 and you go to 5 or 10, there's no way the liver will catch up with this, and this causes many, many problems, because they're not generating enough of albumin, liver. And they can be producing many other proteins, like, let's say, inflammatory proteins, So it could be really, it turns wild then. And we'll talk about the consequences, and it's very important for the nephrotic syndrome, but before that. So, with nephritic, it's very simple for you. You imagine inflammation. So if you cut the glomerulus, there's going to be some immune cells, and they're going to sort of, fight whatever they think they are fighting. So they're going to produce mess over there, which is bad. It's bad for the glomerulus. It's destroying the glomerulus and whatever. But what about nephrotic? Well, there are many terms you should imagine. And again, I'm repeating the term I used before. And basically, there are more synonyms in a way that you can look at these two extremes, nephritic and nephrotic. And people in literature are using these like interchangeably, these terms. I'll try to clear it out for you. So, nephrotic syndrome means rather, and we can use the general term I used before, which I like very much because everyone understands the arthritis and arthrosis. So, glomerulonephrosis. Okay? So, the inflammation is lacking over here. And this is a very general term. Or because there is not this inflammation, and we're going to talk about it more. So also typically if there is an inflammation in the glomerulus, which is in the glomerulonephritis, the other term you should bind with this is proliferation. So some people use for all of these, the whole spectrum, they use only term glomerulonephritis, although they know if it's the nephrotic spectrum only, that they know there's no inflammation, but still they use the glomerulonephritis term. And how they divide it is, this one they call proliferative glomerulonephritis. Okay, so it's the same. That's the synonym. Okay, and this one they don't call glomerulonephrosis, which I like very much, but they rather like it, and they make it a bit confusing in a way, and they call it non-proliferative. Non-proliferative. But they put the glomerulonephritis there. Okay, so glomerulonephritis. But anyways, you're going to remember it's a synonym with the osis, glomerulonephrosis. And the point, what's the difference? Well, in proliferative, you should imagine that the cells, typically in the mesangium, for example, are expanding. They're growing over there. They're multiplying. So the original number of cells in the glomerulus is growing because there's inflammation, and this turns, wild multiplication of the cells. In contrast, in non-proliferative, although glomerulonephritis, the number stays the same. So it's not wild. It's sort of, the cells are not multiplying over there. Mesangium stays in the original size, let's say plus minus. And rather you should focus on the leakage because of the, let's say, mechanical and also changes in the polarity of the, let's say, feed of the podocytes and whatever. Okay?
Can I have a question, Professor?
Yeah.
When you say that the number of cells is growing, you don't mean like the cell of the glomeruli, like the original cells? Like
I mean that. As I said, I mean that. Mesangial cells will multiply. Mesangial. And I'll show you. Don't worry, I'm going to draw it.
Is it not referring to the inflammatory reaction?
It is as well. They're
leukocytes.
Yeah, they're there, and they will somehow interfere with mesangium will expand. They are growing over there. They're stimulated by that.
Like the regeneration.
Yeah.
Due to the
well, they're somehow stimulating it. You don't have to know why. No one knows why, I guess. But you should imagine that they're multiplying over there. So that's why proliferative. Okay, I'll come to this later. Don't worry. So I'm coming back. So in terms of glomerulonephrosis, you can also use another term. And you know this term. It's glomerulosclerosis. And again, if I say glomerulosclerosis, the glomeruli gets sclerotic. Again, you should imagine there's leakage of the protein. So another term, glomerulosclerosis. And this is very much like bound with the nephrotic syndrome. It's used all the time. And basically, I don't want to go so much into pathology and their microscopic and electron microscopic and immunofluorescent, definitions, whatever. But over here, you should imagine, those, let's say we could talk about nodular glomerulosclerosis, which is very typical. Nodular. This is very typical with diabetes mellitus, okay? That's typical, nodular glomerulosclerosis. And you can also remember focal segmental glomerulosclerosis, which is very much in connections with, let's say, other problems. We'll talk about it very soon, okay? And over here, you should imagine the other ones like minimal change disease, okay? And you can also imagine sarcoidosis, and we'll talk about it, don't worry. But remember, basically, non-proliferative glomerulonephrosis or glomerulosclerosis, it's rather less inflammation and more proteinuria, okay? Although, in all of these cases, you can be losing some erythrocytes, okay? Because it's nephritic-nephrotic spectrum. And I'm going to draw it now over here. It's a spectrum. It's not black and white. But the more you go to the left, more you're going to lose red blood cells. They're going to be dysmorphic. There's going to be hematuria. Your urine's going to be Coca-Cola-like. Okay? And you're going to lose less proteins. And if you go more to the right, you're going to more lose proteins and less erythrocytes. And now let's talk about nephritic before we get to nephrotic, like fully. And you really have to know, this is crucial, you have to know it for the exams, you have to know it for clinics, okay? So we're going to talk, if it's nephritic, that means glomerulonephritis, and the main hallmark is the hematuria, okay? So hematuria is, if someone says nephritis, glomerulonephritis, you should see hematuria, and you should see those dysmorphic erythrocytes, which had to go through the glomerulus between the end feet of the podocytes and squeeze out, and that's why they got dysmorphic, okay? So some say they look like Mickey Mouse or whatever, so yeah, those are dysmorphic. So, and this is very crucial for you, because if you're going to do urinalysis and you see these erythrocytes, these dysmorphic ones, it's glomerulonephritis. If you see normal erythrocytes and the urine, there's blood in it, well, that's bad message in a way. Well, of course, glomerulonephritis is not a good message as well. But in this case, well, it could be good or bad. The best outcome for you, if it's a normal erythrocyte, is it's because of a stone, which just went through the ureter and really scratched the ureter and urethra, and that's why you're bleeding into the urine. And this is very typical, actually, and don't be and it's very common, okay? So if someone is losing stones, and typically by lithotripsy, after the lithotripsy, they're very sharp. So if they go through the ureter, they cut the ureter and urethra and whatever, and you are bleeding, and you can bleed for a week after stone removal. So you don't have to be so afraid. So remember, of course, you should, they're peeing wine in a way. They say, hey, I'm peeing wine. Those are the red blood cells. But they're not dysmorphic, they're normal. The blood just comes from the ureters. It's good. That's a good message. The other one, which is very bad message, is you're bleeding because you have a urinary bladder carcinoma, and that's the other extreme, and that's the bad extreme. So always you want to pee stones, and you want always to have stones in a way as a differential diagnosis. So out of these three, you can have glomerulonephritis, but they would be dysmorphic, and then you can have a stone. That's the best message for me, at least. And third one, that could be a tumor, okay? And I'm sure you're going to find more of them. But anyways, remember Coca-Cola or tea-like urine. Or it's tea in all literature, because they don't know how Coke looks like. Now we don't know how tea looks like. We know how Coke looks like. So Coca-Cola. So hematuria, first hallmark. The other one is And crucial is hypertension. Hypertension, always hypertension. And why? Well, you got inflamed. Most of the glomeruli, again, you shouldn't imagine that it's like, it can be just a part of the inflammation can be in part. It depends what kind of process is there. But doesn't matter. It can be part of the kidneys. If it's going to be like systemic, some immunocomplexes, yeah, well, it's going to be everywhere, basically. But you should imagine also that because there's inflammation, the perfusion of the juxtaglomerular apparatus is not as good. So that's why actually you are generating lots of renin and you're activating the RA axis, and that's why you should always remember hypertension over there. That's one of the explanation. Of course, you are also not getting rid of the water because the glomeruli are inflamed, so you have oliguria, so this goes with the hypertension as well, okay? But depends what was first. Maybe you're having oliguria because the RA axis is activated. Well, whatever you want, remember there's hypertension. It's almost must. So hematuria, hypertension, that's obvious. Then, because you're having proteinuria, okay? You're having proteinuria. And that's very typical. There's inflammation, but it's going to be less than 2 grams per day, okay? But it's serious. So you can have, and you're going to have, because you're retaining water, you're having proteinuria, so the oncotic pressure is going to be somehow decreased. So you're going to have edemas. And they're going to be everywhere. Of course, remember, around eyes, it could be slight. Not so bad as in nephrotic syndrome. We're going to talk about it very soon, but you can see it. And remember, always when I'm telling you edemas, what edemas you always should think of as well? Lung edemas, please remember they can have lung edema to it as well. This even more accounts for the nephrotic syndrome, okay? So edemas everywhere, but also lungs, don't forget that. So pulmonary edema. So that's, yes.
A question, can this fluid, can it also enter the pleural space? Like the intrapleural?
Basically, remember, I don't know, it depends how severe it is. In nephrotic syndrome, definitely, because you're having ascites, and if it's nephrotic range, if it goes over 3.5, you're going to have it. So look on nephritic syndrome as a lighter edemas. Of course, it depends how much you're going to retain the water. If you have anuria, you're going to have like water everywhere, but that's going to be mostly, let's say, gravity based, and swollen ankles and whatever, because the oncotic pressure is pretty okay. As I told you, if your liver is healthy, of course, if someone's going to be cirrhotic and is going to have glomerulonephritis, is going to have like really edemas, the same edemas and severe and serious edemas as he would have nephrotic range proteinuria, because he's just not able to catch up even with the 1 gram per day or 2 grams per day loss, okay? So always think of this like, and unfortunately for you guys, well, guess what? The people are getting older, and as you're getting older, it's not like you're having only this disease or that, but you combine the diseases, okay? It's always a sort of a puzzle, that you have to sort of, and with one outcome, but it's a combination of many problems together. Anyway,
Professor,
yep.
In both conditions, for the treatment of the edema, it can be treated with diuretics.
Always remember, not diuretics. Watch out, not diuretics. Antihypertensive, ACE inhibitors, as I told you. Of course, if it's a glomerulonephritis, it's inflammation, and we're going to talk about it. But first, you're going to use the corticoids, as we said. But if the glomerulus is getting destroyed by the pressure which is there, the ACE inhibitors are our first drug of choice, okay? Especially with the nephrotic spectrum. That's like in nephrotic, it depends. If there's inflammation, you're going to try to stop the inflammation by corticoids, and then heavier arsenal, which is cyclophosphamide, okay? And if it's nephritic, you're going to combine it with ACE inhibitors. So you stop the inflammation and you decrease the load on the glomeruli by ACE inhibitors or ARBs, the angiotensin receptor blockers. But ACE inhibitors are crucial. In nephrotic syndrome, you directly start with ACE inhibitors, of course. So ACE inhibitors are like magic word for most of the glomerular diseases. Okay, so remember that. Yep, ACE inhibitors. Okay, so, but still, if we talk about nephritic end of the spectrum, then watch out. If it's a really, really, really awful fulminant serious glomerulonephritis, then you can expect the GFR is going to go low as well. So in serious cases, what? If the bun and creatinine goes up, they can go up, you are having azotemia. Okay? If it's a serious. So, and remember, of course, you're going to do, in this case, biopsy. If you don't know what's happening, biopsy is the procedure of choice to really find out what's happening. But I'll talk about that later. So, but azotemia and glomerulonephritis, yeah, it's possible. Okay. In contrast to this, we're going to hop on the other side. That's the nephrotic side. So, once again, all nephritic can end, but don't have to with nephrotic syndrome. Okay, and you're going to find it out once again either by it's more than 3.5 grams per day, or if you take a single spot urine and you put the ratio of the proteins and creatinine, if it's more than 2:1, like 3:1, 4:1, you are having nephrotic syndrome. And what's the main thing? Well, it's the edema. That's crucial. Edema, it's a very serious edema. It can be really awful, like especially in the morning when they wake up, like the whole face can be swollen. Because during the day later, the water goes down, to the feet. But in the morning, that's typically, you see it so much. And that's eyelids, that's pretty horrible in some cases. But this is in case of really serious hypoalbuminuria, which is another magic term. So you're having proteinuria and edema because of hypoalbuminuria. And this is below like 3 grams per deciliter. Okay. 3 grams per deciliter. So it's gonna, if it goes below that, you're gonna have serious edema. So first of all, decreased oncotic pressure. Okay, good. And of course, again, lung edema. Always, like I will stress it again: lung edema and ascites and pleural edema and whatever you want. Okay. Interestingly enough, over here in most of the cases, and I really was checking it out, you are rather normotensive. So if there is not this inflammation, rather you won't have a serious hypertension. And this could be again because of the decreased oncotic pressure, which decreases normally the pressure by n to 10%. So if you have decreased oncotic pressures, the pressure will decrease naturally, by so much actually. So, and remember with the edema, the worst ending could be anasarca. So you are full of water. Okay, so anasarca is the extreme. Anyways, so you're losing proteins and in really high amounts, and the healthy liver are not able to catch up with this. What this means? Well, this means that also you're losing special types of proteins which are responsible. I'm talking of the apolipoproteins that are responsible for guiding the fat in your body. And because you're losing these as well, now it gets like the fat metabolism gets wild. And you're having dyslipidemia, or we can say hyperlipidemia, and maybe even better term, hyperlipidemia, or even better term is dyslipidemia. Because dyslipidemia, remember, it's a golden word. If someone says dyslipidemia, Basically, he means increased levels of all the bad fat like LDL and VLDL and not enough of HDL. And this means what? Atherosclerosis. So dyslipidemia means atherosclerosis. And atherosclerosis is like 10 times faster now. So your vessels are like aging 10 times faster than your calendar days. So if you hear about someone, yes, nephrotic syndrome, yeah, you can just imagine how the arteries are getting like old rusted pipes, awful rusted. That's why these people will have heart attack, MI, or stroke very easily. And they're typically dying on this, okay? Okay, so watch out. You're having dyslipidemia and you are losing lipids into the urine, so you're having lipiduria. And this is a important test question. Remember, on microscope, if you're going to do urinalysis on microscope, Maltese cross or crosses. There are many Maltese crosses. Those are lipids in the urine. So remember, this is a typical sign. This is an important question in all kinds of tests you're going to write. So Maltese cross, that's the answer. It's because that's typical for nephrotic syndrome, okay? And because you're losing all kinds of proteins from the blood, you are also losing, unfortunately, protein C, S, and antithrombin 3. And what? Protein C and S, you know, what does it do? Well, an antithrombin 3, you know as well. Antithrombin 3, what? Binds heparin or heparan sulfate, which is it's part of the glycocalyx of the vessel. So antithrombin is crucial. It's produced by liver. And this blocks, factor 2. It's antithrombin. So it blocks the thrombin, the most important enzyme of the cascade. And also like 9, 10, 11, 12 factors. And what does this mean? Well, not only that you're having atherosclerosis and you're going to have MI because there's a thrombus in arteries, but now it's time for DVT. It's time for a thrombus. You have increased risk of thrombus formation in veins, okay? So remember, because protein C, S, and antithrombin, that's the coagulation cascade, and they should stop it, but now the coagulation cascade is overactive, and so thrombi, and it's going to be DVT, so you should be afraid of pulmonary embolism. And not only that, but also there's an increased risk of what? If you're having AFib, watch out. Yeah, you could have a thrombus in atriums, and this could fly to brain as well. So, and you know what's rare? Remember, we're talking about kidneys, and what's pretty typical with this? It's the renal vein thrombus formation. So in renal veins, thanks to nephrotic syndrome, suddenly you can have a thrombus there in the renal veins, which will of course kill the kidneys, okay? That's going to be acute kidney injury thanks to this. So renal vein thrombosis, please remember that's a typical one. And basically, still, I'm going to give you some other examples. So basically, if we want to get more deep in this, remember, and I don't have a space over here, but 1/3 of these, let's say, are systemic. So if we talk about causes, I'm going to mention them later in more details, but already remember, 1/3 is systemic. And what I mean by systemic, I mean systemic diseases like diabetes mellitus, amyloidosis, and SLE. But watch out, SLE is special. SLEs can cause anything from the nephritic-nephrotic spectrum. Basically, SLE is like, it covers all of them, because you can have a serious version which kills your kidneys by serious inflammation, or you can have a slight process which just sort of touches the glomeruli, and that's why you're having only pure nephrotic syndrome. But already remember this, okay? So remember, systemic diseases like diabetes mellitus, amyloidosis, and some cases of SLE will cause nephrotic syndrome. And then you have primary kidney diseases. So it's not systemic, but typically it's connected with nephrotic syndrome. And typically, remember, this is a magic term. In children, the most common cause is, and you call it minimal change disease. Minimal change disease means you don't see it in classical immunofluorescence microscope. The thing you have to use is an electron microscope. And over here, you'll see changes. Some, let's say, we could say structural changes. So minimal change disease typically in children, and it's not a systemic cause of nephrotic syndrome. Okay? And still, one more thing that I should mention. So these are the causes, really, in a nutshell. Remember, still, what are you losing? You are losing immunoglobulins as well in a nephrotic syndrome. So remember, this is serious because you're losing immunoglobulin, so you are not protected everywhere, and especially in lungs, because you're losing immunoglobulins. So you got decreased levels, you are not protected. And what? Why lungs again? Because you're having edema in the lungs, remember? There could be a pulmonary edema. So this combination is very serious because you are afraid of some kind of bacteria, and typical pneumococcus, okay? So that's why what you should do with the patient, vaccinate the patient. So you should vaccinate the patients like directly and preventively against pneumococci because they are in danger of serious pneumonia, okay? So vaccinate. And as I told you already, and I can sum it up in a way with the treatment. So if I mention that, still over here, remember treatment of if we talk about nephrotic syndrome, remember ACE inhibitors, as I said. ARBs, as I said, because they're decreasing the, let's say, you're really trying to protect the glomeruli because they're already destroyed by the protein. So you don't want to you don't really want the pressure to be another factor that will kill them right away. And last thing I told you about dyslipidemia, so remember statins. You want to slow down the atherosclerosis, okay? You want to really slow it down. So this was sort of an overview between nephritic and nephrotic syndrome. I told you more about nephrotic now, but now in the next slides, we're going to talk about the glomerulonephritis more, okay? But still, I told you, and guys, I should stress it later, but maybe I will forget it. So remember, why I'm telling you diabetes mellitus is the most common cause. As a clinician, you will always see someone, if he has diabetes, you will see proteinuria maybe, which is serious. Most of you will see microalbuminuria, like just tiny, small, leakage. If it gets worse, you will see proteinuria. But to see a diabetic with nephrotic range proteinuria, you won't see it. I mean, it's always what is around you, and you won't see it. But it's the most common cause. Why? Because we got almost 500 million people with diabetes mellitus. Now it's like 420 million. So somewhere in India, there's someone with nephrotic range proteinuria thanks to diabetes only. Okay? But it's rare for you because you will see many, many diabetics, but to find one with nephrotic range, it's hard. But if you count the whole world together, it's the most common cause. Diabetes and hypertension together. Okay? Get it? But with the nephritis, for example, IgA glomerulonephritis, which is the most common one, that's for adults, the Berger disease. If you're having this, if you're having this inflammation, yeah, it's pretty probable you can end with nephrotic range proteinuria, okay? Because it's it's killing the glomeruli. So always you have to think of the whole world, what is the most common. And because we have so many people with diabetes, yeah, it's the most common cause of nephrotic syndrome. But if I would say You know, if I would pick, once again, I can see it the other way. If I will take, 10 people with diabetes, no one's going to have nephrotic range. But if I will take 10 people with IgA, very likely some of them will almost lose everything, through the urine, protein. So, well, or they will definitely end, half of them will end with end-stage renal disease. Half of them. Okay? Yeah? Get it? With the IgA nephropathy. Berger's disease, that's the one you should remember. Most common cause of glomerulonephritis in adults. So, we're making a pause 5 minutes. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.